Will, and thanks for having me. So some great talk so far, but we're going to go and talk about if all else has failed, what we do. So firstly, I'm going to talk about the indications for meniscal transplant. I'm going to talk about how meniscal transplant works, the scientific plausibility, which I'll explore in a minute, clinical results that we have, and then finally on whether meniscal transplant is chondroprotective, whether it can prevent or delay osteoarthritis. So the indications have been pretty set for a while. We've heard a few people talk about the meniscus as a stabilizer in the knee. Actually, the first meniscal transplants were put in ACL deficient knees to try and prevent further instability, but we don't do that routinely anymore. The ideal indications are patients that have had a previous meniscectomy, and that's nearly always for a sports injury that has had a previous failed repair or just resected from the beginning, or as we've just heard, if someone has had a previous discoid meniscus that's been resected. They need to be symptomatic, so it's not for asymptomatic patients. In the early days, it's usually activity-related, usually at rest, no symptoms, but as soon as they do too much in the way of activities, they get pain and sometimes swelling. Later on, they get symptoms all the time. These patients are young, so we say age up to 50, but this is really a pathology of young people. The average age in our cohort is 29 for meniscal transplant. And I think when you're getting into the older age group, it's usually a different pathology that we're dealing with. And they ideally need to have good chondral surfaces. And they're the ideal indications. And that's about 2/3 of the patients we see. But then you have a third of patients which have indications 1, 2, and 3, but their chondral surfaces aren't good, but they're still very young and are often yet too young for anything else, and there is potentially a role for meniscal transplant with those patients, which we'll go into. We've heard from many speakers, and I'm going to echo those thoughts. You can't think of the meniscus by itself. You need to look at the alignment, stability, and the chondral surfaces, and you need to deal with them all either before the meniscus transplant or at the time. So how does meniscal transplant work? So I'm not going to labour the point on how a normal meniscus works. We've heard from others, but it is a load distributor. It spreads the forces, spreads the surface area, and reduces your peak contact pressures. The heat map on the left shows the surface area with an intact meniscus. When you have a meniscectomy, you have much higher peak contact pressures, and you also have unloading of the rest of the cartilage, which is bad if you unload certain areas, and it's bad if you overload. The idea of meniscal transplant is it restores the anatomy, and there are a number of biomechanical studies that have shown that meniscal transplant pretty much restores the anatomy and the biomechanics in the knee. So scientific plausibility. I think this is critical for all procedures that we do. I think we need to understand how things work, and we need to test whether they are working in the way we expect. So with a meniscus transplant, we're asking it to work much in the same way as a native meniscus does. So it needs to spread the forces, and it needs to function like a native meniscus. So we've looked at our in vivo patients, so our patients that have all had an MRI scan at 1 year. We try and get a scan on everyone at 1 year, but they come from all over the country, so we don't always manage that. And we have something called a MIM score, which is essentially a measure of meniscal transplant health. It's looking at extrusion, it's looking at flattening, the signal within meniscus as well. And then we're looking to see whether, if the meniscus looks better, transplant looks better at 1 year, whether that's likely to predict a better outcome for these patients. And we'd expect that if it is working the way we expect it to work, a better looking meniscus is likely to have better results. So we have followed these patients up to a mean of 5 years, and we have found that. So we've found that on the y-axis, you have the improvement in Coues score, and on the x-axis, you have a MIM score, which is the highest score is up to 11. And with a line of best fit, there is an improvement in your Coues score if you have an improvement in your MIM score at 1 year post-surgery. And we've put this into a logistic regression model to make sure there were not other confounding factors. The only thing that was significant in the model was the MIM score. It also affects survival, so you have a higher survival if you have a better MIM score at 1 year. So it appears that if it looks better then at 1 year, then the outcomes are improved, which goes to looking at whether we can improve the meniscal transplant appearance with different techniques. So on techniques, there are really 3 main techniques. You have the all soft tissue technique, which is taking the meniscus transplant off the bone block and suturing the routes. You have the bone plug technique, which has a small amount of bone, and then you have the bone bridge technique, which is used for laterals in with some surgeons. There is a theoretical or biomechanical advantage potentially with bone over soft tissue fixation, but this hasn't yet been translated into clinical studies, although most of those clinical studies are small numbers, so we can't really take from that that's definitely true. My take on it is that if there is a potential advantage with bone, then I prefer to do that, and I use bone plugs because I actually don't think the technique is much more difficult, so that's why I use the bone plugs for all cases, medial and lateral. So looking at clinical results now, we have a prospectively maintained database. We have more than 400 patients out to 1 year now with over 90% follow-up, and I've split the indications for ideal and salvage just to show you whether there are differences. So these patients are pretty well matched for most baseline demographics except for two things. One is that they are slightly older in the salvage group, but the time from their meniscectomy to their meniscal transplant is longer. So it's looking like these patients are from the same population. They start with their meniscectomy when they're young, but if they present to us later, they're more likely to have a salvage knee with full thickness condyle defects, which is, again, what we'd expect with a patient that is struggling with a meniscal deficient knee. The red line is the ideal indications. The first thing to take from it is they both improve. Up to 10 years, we have less data, so it's a bit hard to interpret that, but does possibly falling off with the salvage indications, but both improve. Not statistically significantly different, but possibly ideal indications look a bit better. And that's also shown with Tegner scores, which are maintained in both groups up to 10 years. Where we start to see a bit of a difference is in survival, and with ideal indications at 10 years, we are at 90% survival, which we're pretty happy with. It's significantly lower with the salvage indications. So summarising that, we have biomechanical studies showing that the meniscal transplant appears to work like we expect. We have some scientific plausibility in that a better-looking meniscus transplant appears to have better results and predicts better results. We have case series showing reasonable results, and we did a pilot randomised controlled trial a few years ago which showed an improvement of meniscal transplant compared to physiotherapy, but that was small numbers. So the final piece in the jigsaw is a multi-centre randomised trial, which is actually ongoing and we're recruiting to now. So I would really encourage people to refer to any of these centres if you have a patient that's potentially suitable, because we really want this to work. It's difficult to recruit to. We are recruiting, but it's slow, so any help would be greatly appreciated. Final question is, does meniscal transplant prevent arthritis? Is it chondroprotective? The ultimate answer is we don't know for sure. There are a couple of studies which suggest that there is some chondroprotective effect. The first study on the left is out to quite some time, and it shows that they've matched with a meniscectomy group, which isn't really the same population, because an asymptomatic meniscectomy group is different from a meniscal symptomatic group, but they have shown an improvement, a reduction in joint space width with the patients who have meniscal transplant. And the ones that were more extruded at 1 year, the transplants did worse. So again, it goes to the scientific plausibility that if it is functioning more like a meniscus, looking more like a meniscus, then it works better. And the study on the right shows T2 mapping is improved post-meniscal transplant in patients up to 7 years post-surgery. So summarising that, I think we're pretty clear on indications now. They haven't changed much. Meniscus transplant works in the same way that a meniscus works as a load distributor. It's scientifically plausible that it would work, and we have in vivo data for that. Clinical results are encouraging and have been for some time. We don't yet know whether it's chondroprotective, and therefore it's not really a major indication or not an indication for meniscal transplant. Thank you.